I would like to welcome everyone to this I3 session. This is the session number 131, and the title is Up Close and Clinical. And what we are going to discuss today are basically clinical application and practical consideration, and also the consequences of some of the latest technologies that we see coming into IVF clinics and labs specifically. Before we go any further, I would like to thank the kind sponsor of this webinar, which is Future Fertility. And I would like to introduce my co-host that you see here on the screen, Dr. Kathy Miller. She is very well known for research in the field of blastocyst culture, PGT, and the eye, and she's also since quite a few years back the managing editor of the IFFS Surveillance, and she's also the Chief Scientific Officer of Innovation Fertility, MedTech for Solution, and she also created in 2017 the OvaTools Training Institute. Kathy, thank you for being here with us, moderating the session with me.
Well, thank you for the kind introduction, and it is very nice to also co-moderate with you, Dr. Vassena. Dr. Vassena is co-founder and director of Fecundus, a company dedicated to the development of innovative fertility treatments. And before this position, Dr. Vassena has been the global scientific director of the Eugen Group. She has more than 20 years of experience in the field of reproduction and more than 120 publications in peer-reviewed international journals and book chapters. Tonight, we ask that you all place your questions in the Q&A section and not in the chat section. And please take part in our discussion. I'd also like to introduce Dr. Sergio Papier, our reproductive medicine specialist and medical director at Seeger and Novogen, director of the executive committee of the Latin American Association of Reproductive Medicine, and a past president of Argentinian Society for Reproductive Medicine and the Latin American Association of Reproductive Medicine. It's been a pleasure knowing you, Sergio, over the last 10 years, and I'm excited that you joined Rita and I today in moderating this great webinar. So I think we'll begin, and I'll turn it back to you, Rita.
Thank you very much, Kathy. Let me share briefly my screen so that I can tell you a little bit about my topic for tonight, which is moonshots and last miles, what it may take to treat infertility for all. This is going to be a pretty short talk, but before we start, my interest, you've heard from Kathy that I'm the founder and CEO of Fecundus, so it's a company that works and develops technologies for IVF. I'm also a member of the executive committee of the Spanish Fertility Society, and I'm also an advisor to quite a few startups in the fertility space, among them the sponsor of this session. What I'm going to tell you very briefly tonight is has also been described a little bit more in length in this countercurrent piece in RBM Online, which I've been able to publish just quite recently, a couple of months ago. So basically, what I would like to reflect upon is the situation that we have in IVF. We have definitely a problem of access to treatment. We know that very many people, they know that they have a problem because they're trying to have a baby, to get pregnant, and they realize that this is taking longer than expected and it's not working as it should. However, only a portion of those end up accessing treatment at a clinic. And even those that are able to set foot in one of our clinics, well, they not necessarily start treatment for a number of reasons. And in fact, we know that most patients worldwide do not reach the treatment stage. Why do we have this access problem? There are several reasons, but one of them, and in some countries is the main one, is because we have an efficiency problem. So we know in our treatment that once we have eggs and sperm, that's not the end of it. We know that the journey from gametes to embryos that are viable and they're high quality enough to be transferred to the uterus is one of loss. We lose at every step of the developmental ladder. And also, once we have blastocysts or viable embryos, we are not really sure that they will get into a live birth. And in fact, most of them will not. And so patients end up abandoning treatment before reaching the end of their journey. Or if they are able to stand it both financially and emotionally, they cycle in the system repeatedly until when eventually they're able to have a child. So my question, or what I would like to reflect on today, is why does it happen? Why we have such a big efficiency problem? Why we have such a big access problem in our field? And I would like to offer one way of looking at it. And in my view, well, I would like to expose a little bit the situation that I see. Well, we realize that funding for research in infertility, in order to understand the reason at the base of the symptoms of infertility that we see, is very limited, and it's limited to a very dramatic extent in some area of the world. And we know, for instance, that in general, every type of female dominant condition is systematically underfunded. It is underfunded in the United States, for instance, but is underfunded globally. If I look, in the geographical area that I'm more comfortable with, which is Europe, I checked personally, and the European Commission is the largest, by far the largest funding body for research, for biological research in Europe. And in the last 10 years, they had about 9,000 calls for grants and funding for research, and of those, just 2 directly targeted infertility and assisted reproduction. So this, I think it says it all. So we are without, basically, funding to understand the basic mechanistic reason of infertility. Also, because of the way IVF has developed historically, most treatments are carried out outside of, let's say, knowledge center or university-associated departments, and which limits the access that we can have to data, to sample, and to patient in order to study and then to test possible therapies. Even when this situation is a little bit palliated in certain countries, still we have limitation on what type of patients access treatment in the public service and which of them do receive treatment, which also limit further access to samples and patient. And all this together makes so that mechanistic knowledge research and the understanding of the disease that underlies infertility all but stagnates. If we look at who are the players of innovation, now that the large pharma companies basically have receded, in a sense, from the field, once established their basic product for ovarian stimulation and whatnot, the true innovators right now in this field are smaller companies, privately funded, either in tech or in bio. But what is the issue? Because of this lack of basic understanding of mechanism of infertility, these same players, they do lack, again, basic research and mechanistic insight, and their type of funding that is required to acquire this type of knowledge is way beyond the scope of small companies. Not only this, because they're privately funded, most innovators, they must provide returns in a timeline that is, in agreement with their funding partners. And right now it's mostly it's mostly at the very beginning, either, venture capital funding, and venture capital has a timeline in order to be able to exit and then multiply, that is anywhere between as little as 4 and as long as maybe 8 years maximum. And this type of timeline does not really allow for fundamental research to go all the way to market. And that's for most companies, they focus by necessity on fast wins, which often are operational in nature and incremental in terms of improvement. So considering this situation, I would like to suggest a way forward. From a practical point of view, the way forward in order to be able to treat as many people as possible, not just from an operational point of view, but in order to improve very significantly the results of our treatment, it goes necessarily through closing the knowledge gap that we have at the genetic level and the functional level. It really needs for us to advocate for an increase in funding for research, and also advocate for private-public partnerships that are really critical in a field like ours, where most patients are in the private sector. And it would be great if we could establish clinical trial centers or networks, like, for instance, it happens in the Netherlands, so that we can test before innovation enters the market quite fast and iterate what we are proposing as a solution before it gets to exhausted patients and exhausted clinicians. But on a more, let's say, ambitious level, what we need to really do is to elevate the relevance that infertility has, both for governments and for international bodies. And in order to do that, I think there is only one actor that can do it. And this is where I leave you with my last sentence. I think it's us. We really need to rally together and go through a relentless advocacy in order to improve and put on the center stage infertility at the government level, at the international level, and at the global level. And with this, that I hope will energize all of you, I will just stop here, and then I'll be happy to continue with the webinar.
Thank you, Rita, for that very interesting presentation. I had the unfortunate and fortunate, I guess, honor of, in February, being the laboratory director of the largest fertility center in Alabama. And as we all know what happened in Alabama, I've been doing this for almost 40 years and never thought I'd have a time period in the last couple months where I was just advocating for basic human rights of females and just anybody to build a family. I do agree that that we need to come together as a group. And I don't even think most people would ever imagine in the United States of America that we would be just advocating and fighting for basic rights of women's health care. So how do you propose we come together and do this advocacy?
Yeah, I think there is one aspect. So I think all of us, each of us actually, from their own position is it's the possibility to advocate. You can advocate very locally, and you can advocate at the national or international level. One aspect that I would like to highlight is that, like I've seen actually in the US, and I think it's quite a guiding light in this sense, is how profoundly and how active are patients and patient association in advocating for the importance of bringing light to the situation of fertility treatment, or in general infertility research. So the partnership between all of us that work in medically assisted reproduction and patients, I think it would be a very powerful way forward in my point of view.
I think a lot of comments happen about these new technologies is that they quickly develop because they're underfunded and they have to come to market so fast. They quickly become what we call add-ins. And should the patient be paying for them before they're validated, proof of concepts, and are they valuable? Who do you think are the innovators in the market, and who should we really be paying attention to? And do you think they're here to stay because it's important technology to add to our field?
Well, I think one thing that is definitely evident is that we are in a decade, perhaps, of a strong innovation in our field. And in a sense, innovation has moved from the pharmacological aspects of fertility treatments to a more technological, and they are focusing on the lab mostly. In order to know if something is going to be here to stay or not, well, we will have to wait to see what works and what doesn't, right? And this cycles back a little bit to the overall, in general, I'm generalizing, it's not always like that, but in general, we see innovation coming into the clinics before they are fully validated. Most of the time, we assume or we know that they are safe, but not always necessarily we are sure that they are effective. So to me, it circles back to have a structured way of testing innovation against relevant clinical outcomes. Something that I think we are moving towards, but is still not there, in my opinion.
Thank you for an insightful presentation and an excellent conversation. I'd like to move on to the next speaker, and it's a pleasure to introduce Dr. Danilo Simodomo from Italy. He is the embryology director and science and research manager for in Italy for EVRMA Global Research Alliance. He is also the basic science officer and coordinator-elect of ESHRA's Special Interest Group on Implantation and Early Pregnancy. He's also an associate editor of Human Reproduction and the section editor in Clinical Embryology of Reproductive Biomedicine Online. He's participated in the ESHRA working groups updating the GPRs for embryo biopsy and for RAF management. He also coordinates the Masters of Biology and Biotechnology of Reproduction from research to clinic at the University of Pavia. With that, I'd like to welcome Dr. Simodomo.
Thanks, Katie, for a very nice introduction, and thanks the I3 for inviting me, for having me giving this talk. So I'll be talking about the black box of implantation of euploid blastocysts, and we'll go through it across the slides. So this is my conflict of interest, but none of them is really associated with the content of this talk. So our focus here is the process of implantation. So know that for this to happen, basically you need an embryo that is competent, and by competence, in my view, there are at least 3 levels: developmental competence, chromosomal competence, and reproductive competence. Well, developmental competence is something that we can actually assess by conducting blastocyst culture, and if you get a blastocyst, that means that it reached that milestone. Chromosomal competence, we can assess it by conducting trophectomy biopsy and comprehensive chromosome testing and assessing its euploid constitution. But there are very few additional information that we do have to attempt at understanding why euploid embryos implant or do not implant. And then obviously there is the other side of the coin, which is the endometrium. So we need to transfer a competent embryo in a presumed window of implantation of an endometrium that, according to Backlund and Ambrosen's theory, should be properly balanced between selectivity and receptivity. So now, if we stick to hard data from the literature, Cochrane reviews, multi-center studies, non-selection studies, Well, we know that by transferring untested cleavage stage embryos, we can aim for about 30% live birth rate per transfer. If you transfer untested blastocysts, you can get up to 40%, and both these figures are highly dependent on maternal age. Well, then, if you transfer euploid blastocysts instead, you can aim for 50 up to 70% live birth rate per transfer. Yet, it's not 100. So the gap of knowledge that we need to fill is what we call the black box of implantation. So aiming at trying to open this black box of implantation, what we did together with our colleagues in Columbia University, Federico II University of Naples, and Juno Genetics was using the keywords that you see listed here in this slide in a systematic perspective, in a systematic way, and trying to open the black box. We retrieved from the literature 1,600 items, among which we selected over 370 original research papers and 41 reviews. And we carefully scrutinized all of them, trying to meta-analyze the features that were associated among these studies with live birth rate per euploid blastocyst transfer as primary outcome, and miscarriage rate per clinical pregnancy after euploid blastocyst transfer as main secondary outcome. So in these different boxes, I try to summarize for you all the different aspects that we reviewed. Obviously, there will not be time to go through each and any of these aspects, but in summary, they were related with maternal age, main cause of infertility, uterine conditions, and reproductive history. We assessed BMI and hormonal aspects, endometrial aspects, age and sperm characteristics for the paternal part. Embryonic features, we assess static embryo assessment, morphodynamic embryo assessment, as well as additional molecular tests on top of euploid testing. Then we enter the clinic, so ovarian stimulation, associated aspects, endometrial preparation and transfer procedures, and in the lab, cryopreservation, insemination, culture, biopsy, different operators, as well as different IVF clinics. So all these different features were assessed for their association with the possibility that euploid blastocysts will implant or fail to implant. So let's start from the embryonic features. I will just go through the ones that turn out as significant or at least interesting for future research. First of all, blastocyst quality. So we clustered the results across the different studies in blastocysts lower than BB according to Garner score or better than BB. And here you have live birth rate. You see that if you transfer a euploid blastocyst lower than BB, you can aim for about 28% live birth rate versus 49%. So this is a significant difference. Yet many blastocysts lower than BB are not even biopsied or cryopreserved in many countries and in many laboratories. So this somehow is telling us that although these embryos suffer from a poorer reproductive competence, they can still result in a live birth. Miscarriage rate was pretty independent from embryo quality. What about day of development? So if you transfer a euploid day 6 or day 7 blastocysts compared to day 5, also in this case, these slower developing embryos showed a lower live birth rate per transfer, 39 versus 56%. But again, even day 7 blastocysts, although we should acknowledge their lower competence, they can still result in babies at the end of the story. Miscarriage rate in this case showed a slightly yet significantly higher risk in day 6 or day 7 blastocysts versus day 5. So this is another thing that maybe we would like to acknowledge also from basic science perspective in the future. What about timings of development? Here we have a study, a US study, in which they compare timings of development in the context of euploid blastocyst transfer against miscarriage or live birth. And you see in this study, they didn't show any difference. While we have 3 different studies in which there was an association between, in the study by Rienzi from our group and Evie Valencia, the time of morulation, if it's faster than 80 hours, is associated with a higher competence in the context of euploid blastocysts, the time of blastulation, and in this Turkish study, the duration of the blastulation process from the moment it starts to the moment the embryo reaches full expansion. What about maternal features instead? Is maternal age beyond chromosomal constitution associated with the competence of the blastocyst, or at least with the receptivity of the uterus? Well, apparently, yes, we clustered patients as older than 38 or younger than 38. And although there's not a huge impact, it is still significant. So you can go from 58 down to 53% live birth rate per euploid blastocyst transfer. Miscarriage rate was instead rather independent. What about the previous history? So if the woman already experienced several previous implantation failures, so it's an RIF woman, or several miscarriages, so it's a recurrent pregnancy loss woman, is she more subject to a poorer prognosis when she transfers euploid blastocyst? Well, apparently, for the case of RIF, there is a slight reduction, yet significant. So you go from 44 down to 40%. No difference for miscarriage. Instead, RPL in the context of euploid blastocyst transfer seems rather independent. I mean, the outcome from this condition. Obesity here characterized as a BMI higher than 30, although we know this is just a gross marker of this kind of aspect, so nutritional balance. Yet it's what we have, and in 2 studies it was compared with the chance of success in the context of euploid blastocyst transfer, and there is a huge difference. So obese women at 41%, 42% live birth rate versus 49%, and this is mostly imputable to a higher risk of miscarriage even when euploid blastocyst transfer, from 11 up to 19%. Let's enter the lab. So clinical and laboratory features. The protocol we use to biopsy an embryo. We know there are at least 2 different protocols. The one on the left-hand side was published in 2004 from the Australian group of De Boer and MacArthur, and the one that we published here in Rome in 2014 with Antonio Capalbo. So the former, it's called day-free hatching based method. The other one is a simultaneous zona opening and biopsy method. So the only difference is that in this case, you need to take the embryos out from the incubator to make a hole in the zona pellucida. In this case, you leave them undisturbed until full expansion. Now, 3 studies, of which only one is an RCT, compare the 2 methods. And apparently the method without hatching in day 3 results in 59% live birth versus 50%. So it's perhaps less invasive. Miscarriage rate is pretty independent. It goes without saying that we need to have high control on our operators. And these are 2 studies from our group in which, in different shades of blue and here in green, we have different operators and the live birth rate among them. You see that they are pretty independent from the operator, independently even on how many procedures the operator has performed as soon as it was deemed competent when he started this procedure clinically. So we can say that when you have well-monitored operators and well-trained operators, the results are pretty independent. What we should keep under control instead is cellularity. So the number of cells that we retrieved in our trophectomy biopsy. This is a nice study from the group of Richard Scott and Shelby Neal as a first author. You see here in purple the 4th quartile in the number of cells retrieved in a trophectomy biopsy. In this case, with respect to all the other clusters, we have a reduction of the live birth rate per euploid blastocyst transfer. So if you take, let's say, more than 15 cells up to 20, these might have an impact on the chance of implantation. But in my view, it's common sense that we need to limit the number of cells that we retrieve in our biopsy. About 5, no more than 8, 10. It's a reasonable number of cells. What about blastocyst rebiopsy? So we know that sometimes it might happen that you don't get a result, you have an inconclusive result, so you need to warm rebiopsy and revitrify the embryo. Is this showing an impact on the live birth rate? Well, apparently no, although there is a trend towards a lower live birth rate. It wasn't significant, no difference in terms of miscarriage. The other thing that we need to take into account here is that obviously rebiopsied embryos are normally transferred to poorer prognosis women that already failed from control embryos. So this is another thing that we need to take into account, especially when meta-analyses are conducted. What about comparing fresh versus vitrified worm transfer? So in the context of euploid blastocyst, and so in PGT, apparently there are two studies, only one is an RCT. Transferring a vitrified worm embryo is better than a fresh embryo, 58 versus 48% live birth. But again, it goes without saying that a fresh embryo transfer in the context of PGT is not the same as in the context of non-PGT cycles, because obviously to perform fresh embryo transfer, we need to postpone the transfer of an embryo that was perhaps ready earlier, because we need to wait for the results of the PGT analysis. So this can somehow desynchronize the endometrium and the embryo. And what about instead endometrial preparation? So we compared HRT versus modified natural cycle. The results were pretty similar, at least from a statistical perspective, in terms of live birth and miscarriage, although the results were slightly poorer when an HRT is used with respect to a modified natural cycle. So all these data that I summarized for you in these slides are in this paper that we published in Human Reproduction Update last year. This is the graphical abstract of the study, so I will just summarize it in words for you. Why do some euploid blastocysts fail to implant? Well, basically, one reason is maternal aging and obesity. So in my view, we need systematic and appropriate evaluations in the future of these aspects. Issues in endometrial receptivity and or selectivity, and more investigations from a basic science perspective are definitely needed. Reduced blastocyst quality defined through whatever you call it, static or dynamic assessments. But here I want to say that standardization is eagerly needed, and perhaps AI tools in the future might help us to standardizing how we code the quality of an embryo. Excessive or poor embryo manipulations, and that's why we need well-trained and constantly monitored operators adopting validated protocols, whatever we do in the lab, from ICSI up to blastocyst biopsy. Obviously, the study is not without limitations. All the studies included were mostly retrospective studies, subject to large heterogeneity. Therefore, the level of the evidence was considered low or very low. And the other thing is that some of the present findings represent just prognosis without promise. That means that we just really need to acknowledge that, for instance, a woman older than 38 is more subject to poorer live birth in the context of euploid blastocysts. It's not something that we can act on. It's not actionable, but still, it's something that we can acknowledge and counsel our patients with this information. But what about the other side of the coin? Well, what about aneuploid blastocysts? Do they implant? Well, here the question should be reformulated, if you like. Do embryos that have been reported aneuploid based on a single biopsy result in a healthy live birth? This is a very nice review. It was published by Antonio Capalvo in the American Journal of Human Genetics, and he was putting together with his colleagues all the studies in which embryos were biopsied and transferred without analyzing the biopsy. So the biopsy was just kept in the freezer, waiting for the results of the pregnancy test. So when they had the results of the pregnancy test, they went blindly back to the biopsied fragment to see whether the embryo that was transferred would have been called euploid or aneuploid. So this is what we call the non-selection study, and is very useful to assess the positive and negative predictive values of our test. With this kind of approach, well, embryos that would have been called aneuploid were actually transferred across about 10 years in the literature. Over 300 aneuploid blastocysts were transferred, and they resulted in less than 2% live birth rate. So this is perhaps the risk of the clinically relevant risk of error when we perform PGT without reporting mosaicism. Yet the risk of miscarriage was very high. If an embryo called aneuploid would implant, in almost 90% of cases, it will result in a live birth. But let's focus on the first two studies in this list. These are two studies from the same group, RMA in New Jersey. The first from Scott in 2012, the other one from TX in 2021, so 9 years apart. The live birth rate per aneuploid embryo transfer in the first study was 4%. In the second study was 0%. How it comes? What was the difference? The same center, the same authors. The difference was the method. Okay, the first study was whole genome amplification based SNP array, while the second study instead was targeted NGS. This is just to tell you that the technique that you use might be less or more exposed to false positive results. So these are technical reasons why might implant an aneuploid embryo. The other reason is biological, it's mosaicism. So we know that the situation here is not black and white. There is a third constitution, which is euploid and aneuploid mosaicism. So the presence of both euploid and aneuploid cells in our embryos. What is the only way to assess mosaicism in human embryos? Well, basically to conduct research studies in which you use embryos donated for research that are disaggregated in the inner cell mass and multiple multicellular fragments of the trophectoderm. Well, these kind of studies have been conducted across the years. In 2019, Mina Popovic very nicely reviewed 11 of them, and up to more than 500 embryos, and even more nowadays have been biopsied, fully analyzed with this kind of study design. And well, the estimate of mosaicism in human blastocysts with this kind of approach is somewhat between 4 and 5%. Yet clinically, many laboratories are reporting mosaicism just based on a single biopsy and what we call the intermediate chromosome copy number. So I used this cartoon that was very nicely provided by Francisco Antonio Carrera Sorensen, that is summarizing what an intermediate chromosome copy number is. So from a single biopsy, you get different chromosome copy numbers. Here, these black bars represent each of them. On this axis, you have chromosome copy number from 1 up to 3. And here you have a magnification of chromosome 17, 18, up to 20. Now, if the chromosome copy number falls in this range, that's a disomic. So it's normally, for autosomes, it's fine. You have 2 copies. If it goes beyond this range, it's a full trisomy. Below this range, it's a full monosomy. Now, the problem is that sometimes chromosome copy numbers fall in between disomy and trisomy or disomy and monosomy. This is what it's called an intermediate chromosome copy number. And this is what it's used in many centers to call mosaicism based on a single biopsy. Now, while it is true that intermediate chromosome copy number might be due to the presence of both euploid and aneuploid cells in your biopsy, when you report mosaicism based on intermediate chromosome copy number, up to 20% of human blastocysts have been reported mosaic, which is much higher than the 5% that Mina showed by looking at the whole disaggregated embryo. So this is basically the difference between these two rates is based on the fact that, as also the PGDIS acknowledged, the rate of mosaicism has been over-exaggerated when reported based on intermediate chromosome copy number, because intermediate chromosome copy number might be also due to a plethora of different technical and biological confounders, such as statistical variation, DNA amplification bias, contamination in our biopsy, mitotic state of the cells that are physiological replicating their DNA, and poorly conducted biopsies. So that's something that we need to acknowledge. So the only way out of this was to conduct again a non-selection study in which Antonio Capalbo at iGenomics back in those days was not reporting mosaicism clinically. So the embryos were reported just euploid, even if in other clinics they would have been called low-grade or medium-grade mosaic. So we were actually transferring for 2 years blindly putative mosaic embryos as if they were full euploid. After 2 years, we unblinded the results. And as you can see here in green, yellow, and brown, the results between euploid, low-grade, and medium-grade mosaic were absolutely comparable. So in other terms, it was clinically meaningless to report mosaicism. The only risk is that fully euploid embryos, or at least competent embryos, would have not been transferred. So just like this is not a pipe, it's a draw. This is not a mosaic embryo, it's just an intermediate chromosome copy number. So we should not use this, in my view, to call a mosaic embryo. And I'm approaching the end of my slides, it's very risky to call an embryo abnormal, putting under this umbrella term in the same basket both aneuploid and alleged mosaic embryos. So they are not the same thing. They're absolutely different embryos. That's why we wrote a letter to the editor to that paper saying that we should avoid mixing apples and oranges, because this might have a huge impact on the lay press. You can read, journals claiming that defective embryos can self-correct and implant. That's something that has never been demonstrated. Or I'm translating here from Italians, from Italian language, healthy babies born from affected embryos. So this is extremely, extremely risky, especially when we need to counsel our patients and to explain something that is very difficult to be understood. But it has also an effect on clinicians, on professionals, because if you ask to clinicians, would you transfer a mosaic embryo, up to 75% of them will consider them aneuploid while they are not, and not transfer them. This is the data, the most recent from the ESHRE survey conducted in 2022. So just my last slide. If in our study, in our non-selection study, we wouldn't have transferred low-grade and medium-grade mosaic, our patients would have suffered down to 40% reduction in the cumulative live birth rate. So if you ask me what is another reason why euploid blasters will not implant, if you don't transfer them by calling them mosaic. And with this, I thank you for your attention. And if you like, I invite you to this ESHRE campus that together with my SIG, we organize in Stockholm in a week or so about a very hot topic nowadays, which is microbiome in reproduction. Thanks for your attention, and I will be more than happy to take your questions.
So thank you very much, Danilo, for this very beautiful and very comprehensive talk. There will be, I'm sure, a lot of questions for you in the Q&A. I would like to start just by one, and then we move on to the next speaker. For now, I've noticed in your review, as you actually mentioned, that the quality, I mean, many studies were retrospective and very heterogeneous. I also noticed that for many of the outcomes that you have analyzed, there were perhaps 2-3 studies at most, which I guess perhaps highlight the need for more studies. So do you have a comment on this, like very few studies dictating somehow or making the whole of the evidence that we have?
Yeah, you know, that's the problem, especially when you're conducting meta-analysis, because in order to meta-analyze the data, you need to find something that is common to the different studies. So, you know, when it comes to clustering the data, for instance, for paternal age or maternal age, it's very difficult because there are studies that are using them as a continuous variable, some studies that instead are categorizing based on like any kind of criteria they choose or they will pick. So that's not easy, and the amount of information to summarize was a lot. There was like maybe 60 figures in the study.
Yeah.
So some of the papers that we couldn't include in a meta-analysis were just included as qualitative data. So there is also a table that is reporting what they concluded. And I mean, it's a pity because I think that if we would be more standardized in the way we assess the results, that would be definitely easier to conduct this kind of analysis. But the point here was just to shed light on what's the state of the art, so that, I mean, there's something that it's pretty clear, like blastocyst quality or day of development, but there's something that maybe requires more investigation, such as the sperm contribution, the paternal contribution, or BMI, for instance. But I mean, the idea was just to understand where we are settled now so that we can move from that and try to evolve the field in the future.
Definitely. Yes, definitely. And I guess you hit it right on the head with the need for standardizing. I mean, I really long for a standardized glossary of what it means, things that we do. You know, like an abortion is a different thing if you ask different people. So I can only imagine.
Where you set the threshold, 20 weeks, 22 weeks, 18 weeks,
exactly.
Whatever you do. I mean, many studies, we could not include them because our primary outcome was live birth. And many just report ongoing pregnancy beyond 12 weeks. And then you need to call the authors and ask if they followed up the results, and many of them didn't. So that's pretty much the point. But we wanted to have live birth because it's way more important than ongoing pregnancy. We would like to have carriage as well there.
Yeah, no, it's definitely the outcome that everyone is interested in, of course. Well, thank you very much, Danilo.
Thanks.
Let's move on for now to our next speaker. Let me introduce her. Is Julien Fistad. She has a bachelor in biology from the University of Victoria, and she's a clinical embryology from the University of Leeds. She is also the head of clinical embryology and scientific operation for Future Fertility. And her passion, so to speak, is to partner with clinics and make sure that the onboarding of the innovative AI tool that they are developing at Future Fertility is smooth and goes on without any issue. So, Julien, the floor is yours whenever you want.
Thank you so much for the kind intro, Rita. Hopefully everyone can see my screen okay. I feel like I've got some big shoes to fill following the last conversations. They've been wonderful. Today I'll be speaking about our recent manuscript in RBMO from January of this year, surrounding our work to develop an AI tool to predict blastocyst development from images of M2 oocytes. Let's see if this is going to behave. As mentioned, I'm head of clinical embryology and scientific operations at Future Fertility, the team that developed the AI model for oocyte assessments that I'm going to discuss. And I'd like to start off with a question. This is a fairly easy one. I know you guys can't actually answer me, but what is the quality of these blastocysts? When we're asked to assess these, we can utilize either visual standardized grading systems such as Gardner, Alpha, even Papier, if we're trained embryologists. And again, this is a sperm sample, maybe a little bit hard to see, 2 different ones here, but can we assess this? Yes, of course we can. We have standardized visual assessment tools to be able to do this, such as WHO or Kruger and so forth. But when I show you images of oocytes, what is the reproductive potential of these? Assuming good lab protocols in normal semen analysis, can we predict if these oocytes will fertilize and develop into blastocysts? Both oocytes look fairly unremarkable. However, the first failed to develop into a blastocyst, while the second one became a high-quality Gardner grade 6AA. Almost every step of the IVF process is assessed, from patient hormone levels, sperm and embryos in the lab, to the endometrium prior to transfer. However, unlike sperm and embryos that follow well-established guidelines and grading schemes, there's no validated visual oocyte scoring system used in clinical practice. Although the patient age is often used as a proxy for oocyte quality, it cannot account for variations within oocyte cohorts, patients of the same age, or between IVF cycles. Unfortunately, oocyte morphology is not well correlated with competence, and the absence of dysmorphisms is accepted to indicate either good or high quality oocytes. Furthermore, visual assessments by embryologists are prone to subjectivity and have shown a predictive value of no better than a flip of a coin when we look at eggs. And while cleavage stage embryo development and patient age provide some insights into oocyte health, we are still missing an incredible amount of valuable information. Thus, hinders our ability to create a manual, clinically validated tool. However, AI is already being applied across healthcare and more recently throughout the reproductive medicine field to support clinical decision-making. Many of us know it's being used to optimize stimulation protocols, determine the best data trigger, assist with sperm selection for ICSI, embryo evaluation selection, as well as provide other clinical insights and efficiencies to optimize the process, provide transparency, and to help ensure standardization and objectivity, as we've been speaking about, is much needed of our IVF practice. So to address the lack of understanding of oocyte quality and our inability to visually assess them within our routine lab workflows, we realized that AI was the perfect application. It was able to do something that humans cannot in this case, and in a non-invasive manner. Deep learning models can learn from large quantities of raw data, analyzing images at the pixel and grayscale level. Combining this with microscope setups and imaging technology provides us with the potential to actually quantify oocyte quality in a novel manner. And we can look for patterns too complex or undetectable to the human eye. From the literature, we found several studies in the area that attempted to apply AI to oocytes. Some of this preliminary work focused on performing textural analysis of the ooplasm, but unfortunately they missed the opportunity to assess information from also the zona and the perivitallin space as contributing factors. Whereas some of my recent work performing image segmentation to assess specific structural features of the oocyte were actually successful in automating the feature extraction and identifying established segments of the oocyte, they were unfortunately faced with major limitations as they did not attempt to then predict clinical outcomes or had been built and applied to very small data sets. Our objective was to then develop and validate a non-invasive deep learning tool that predicts blastocyst development from two-dimensional images of fresh, mature oocytes. To accomplish this, we needed a much larger and diverse data set, representative of different geographies and patient demographics. To develop our initial model, we performed the original research by utilizing a clean data set consisting of just over 37,000 static, single-plane JPEG images at about 200 to 400 times magnification of the oocytes. Data was collected from 8 fertility clinics in 6 countries over the years of 2014 and 2022. A subset of the data was allocated to test the model performance, which was almost 8,000 images and outcomes, and an external validation was conducted on new unseen data consisting of about 12,000 images and outcomes from 2 fertility clinics in 2 countries over the years of 2017 to 2022. And this was to assess the generalizability and the robustness of the model to ensure that it could work not only in the clinics that we built it on, but in other clinics around the world. A little bit of a description of our data set. Our data included all ICSI patients with a complete IVF outcome recorded. Poor quality images were removed, so those that were perhaps dark or blurry and could not be assessed. And the remaining images from this clean data set of about 37,000 were split into train, validation, and test. Oocytes were then assigned binary labels of either positive or negative based on the outcome of reaching a Gardner grade of 1 cc or greater. Now, I know this is a very low Gardner grade, but our reasoning for this was to look specifically at, did it become a blastocyst or not the quality of that blastocyst, and ensure that we're not looking at morulas or cavitating morulas. The output was a convolutional neural network, which was in the form of violet probabilities or magenta scores. To develop the model, a combined total original dataset plus the external dataset consisted of almost 50,000 oocyte images with the corresponding reproductive outcomes, which consisted of fertilization and embryo development up until the day 7 blast. Images were labeled according to oocyte development, and the model was trained to distinguish between a binary negative or positive reproductive outcome of the oocyte. A negative outcome, of course, was an oocyte that did not develop into a blastocyst by day 7, which was either the result of failed fertilization or arrested embryo development. While a positive result is an oocyte that did develop into that blast by day 7 and that minimum grade of a 1 cc. Although we had fairly even distribution of positive and negative classes, we further account for this in model development by oversampling to better balance these. Model development itself required several steps. Our first step was image pre-processing, which included cropping the area of the image to focus only on the oocyte. It also included some data augmentation. Our second step was model building and training using various deep learning architectures to select the best architecture according to model performance, which ended up being the efficient net B7. And we fine-tuned this architecture for our unique task of oocyte classification. Our third step was to assess the performance on the test set, plus conduct subgroup analyses, which consisted of age, sperm quality, and clinic location. And finally, we conducted external validation in the new unseen data set, which will be shared in the following slides. As our deep learning model assesses images of M2 oocytes and provides a probability of developing into a blastocyst, the blastocyst probabilities are generated by the model, which are then converted non-linearly into scores from 0 to 10 for simpler interpretation. A decision threshold was set for the model, which was positive for blastocyst development if the probability was greater than 0.5, and it was negative if the probability was less than 0.5. To note, for those of you that are not in AI or machine learning, an AUC of greater than 0.5 indicates the model has an ability to distinguish between a positive and negative class, and a higher AUC equals a better performance, whereas an AUC of 0.5, there is no discrimination. And what we found actually is when embryologists assess oocytes, their AUC is about 0.5. We're not very good at determining if that egg will become a blastocyst or not. And in the end, the performance of our model was assessed with a test data set and an external validation set, which I'll explain. So the performance on the test data set, as our model output equals a probability from 0 to 1 of an oocyte developing into a blast, Performance was assessed by various metrics, including balanced accuracy, sensitivity, specificity, area under the receiver operating curve, ROC curve, and the model performance on the test data set of almost 8,000 oocytes from 7 clinics, as seen on the ROC curve, achieved an AUC of 0.64. So this is higher than the 0.5, where there is, it's not predicting at all. Here it is able to actually classify those oocytes and can do it better than embryologists. And when we assess the confusion matrix here, we can see green indicates where the model correctly predicted whether an oocyte would be a blastocyst, positive or negative. And this is the true positive or negative. So the model was found to actually perform better with respect to identifying the blast positive class with a sensitivity of 0.65 compared to the blast negative class with a specificity of 0.55. Accuracy and balance accuracy, which is defined by the means of both the sensitivity and specificity of a binary classification model, were both at 0.6. When we performed our subgroup analyses, we conducted this on a test data set for oocyte age, the exclusion of male factor, and clinic location to further assess the performance and clinical relevance of our results. Oocyte age was divided into the following groups for analysis: less than 30, 30 to 34, 35 to 37, 38 to 39, and over 40. The ranges were chosen based on statistics regarding the age-related decline in the percent of ICSI cycles resulting in live birth. We excluded donor cases where the age was unknown, and the AUC of the model displayed predictive power in determining which oocyte would develop into a blastocyst across all age groups, with the highest performance in the age groups 38 to 39 with an AUC of 0.68, and those from 35 to 37 with an AUC of 0.65. There was significant difference in model performance observed between age groups of 30 to 34 and 38 to 39 years, as well as 38 to 39 and those over 40. This aligns well with the general relationship between age and declining oocyte quality. However, we should note that although the over 40 age group didn't follow the same trend, and I'll comment on that soon. For our subgroup analysis based on sperm quality, the largest clinic data set with complete sperm parameters was assessed. This was Clinic 1 and had almost 5,000 images of oocytes and their outcomes. It was used to assess the impact of male factor on model performance. 2 subsequent analyses were conducted to focus solely on oocyte quality as it pertains to the subsequent embryo development. In the first analysis, only oocytes that were inseminated with sperm pre-processing concentration of greater than 15 million and a motility of greater than 40% were assessed. We called this sperm condition 1, and we excluded about 2,300 images. In the second analysis, only oocytes inseminated with sperm with a pre-processing concentration of over 1 million and a motility of 10%, we called this sperm condition 2, were assessed, and this removed about 900 images. These thresholds were based on WHO criteria, and both AUCs from both of these sperm conditions were around 0.68. So neither of these significantly differed from the unfiltered data set for Clinic 1, which was 0.67. You can see that there. Furthermore, despite about 48% of the Clinic 1 dataset comprising of male factor cases, removal of these cases did not influence model performance. A plausible explanation for this may be that the effect of male factor is actually reduced as the embryologist directly selects which sperm to inject during ICSI. So remember, we are only looking at ICSI cases. This thus bypasses the fertilization obstacles of sperm binding with the zona and subsequent ulema fusion. However, it was noted in our model performance that we had a reduction in the patients over 40 years old. Now, this could be due to the fact that oocytes have the inability to repair sperm DNA fragmentation as they age. Just one possible suggestion, but obviously more research could be done in this area. Our final subgroup analysis was to assess the influence of clinic-specific protocols and patient demographics on model performance. Subgroup analysis by geographical location of the clinic was conducted on the data from the independent clinics in Canada, the US, and Spain, as they contributed to the majority of our test data set and had the highest individual sample sizes to allow for a statistical comparison. AUC for these values of these clinics were 0.67, 0.62, and 0.65 respectively. Only the AUC of Clinic 1 with an AUC of 0.67 differed significantly from the overall model AUC of 0.64. However, performance of the model was found to be superior or comparable between the independent clinics and the overall test data set, showing that the model is more than capable of performing on diverse data, lending to its generalizability and robustness. Finally, our external validation dataset consisted of just over 12,000 images from 2 clinics, Clinic 1 and 7, comprised of about almost 5,000 blastocyst positive and 7,500 blastocyst negative outcomes. The model performance was assessed and displayed an accuracy of 0.59, a balanced accuracy of 0.58, and an AUC of 0.63. In addition to the successful applicability of the model on the new data sets, we also determined that the model could actually assign oocytes into statistically meaningful score groups. So we broke the scores down into quartiles. We labeled them A to D, and these quartiles went from 0 to 2.5, 2.6 to 5, and so forth. A positive correlation between a higher oocyte score and the probability of blastocyst development was confirmed, with a significant difference in scores assigned to oocytes that developed into a blastocyst, with a mean score of 7.0 compared to those that did not, with a mean score of 5.4. Additionally, within the quartiles, a stepwise positive correlation between score groups from A to D was seen, with the proportion of blasts from those oocytes increasing from 18.8 to 35.7, 42.4, and 47.6 respectively. And there was significant difference between each of these groups. Additionally, we saw that there was a positive correlation between the oocyte score and the quality of the blastocyst development that develops. So again, this isn't what we built the model on, but if we did look at blastocyst quality, we could see that there was a difference with mean scores of 5.4, 6.7, and 7 for oocytes that resulted in failed blastocyst development, poor quality blastocysts, and those of good quality blasts, respectively, with significant differences found between each of these quality scores. However, I would like to point out there was, of course, a few limitations within our study. We chose an endpoint of a blastocyst as our predicted outcome of interest instead of live birth, which is the ultimate goal. However, this avoids the effects of the many confounding variables that determine live birth success that we cannot always account for. It was a good starting point for AI applied to oocyte evaluation. Secondly, the blastocyst stage was chosen as opposed to blastocyst quality, and our reasoning for this was because even a poor quality blast may still be transferred, depending if that's all that's available for the patient, and variations in clinical practice and patient preference exist. Our external validation, however, does show that the model also correlates with blastocyst quality. However, as we know, embryo grading is also very subjective. And finally, the last limitation to point out was the opacity of our AI system. Because we use deep learning, which is often considered a black box, it is hard to understand the predictions that it provides. There's a high number of parameters and complex interactions between the features that the model can assess. However, with oocyte evaluation, as we are limited in our understanding of what contributes to oocyte quality, we didn't want to tell the system what to look for. Thus, the deep learning solution is able to learn from the raw data and eliminates our need for feature engineering. Currently, as there's no standard evaluation tool available for embryologists and clinicians to counsel patients about their chance to obtain a blastocyst stage embryo from oocytes, an AI model that can consistently and accurately correlate an image of an M2 oocyte with its downstream reproductive outcome can help address this gap and has several clinical applications. It can enhance patient counseling with objective, personalized information. It may provide tangible data to help manage patient expectations. And it may also help us shift the focus from oocyte quantity to quality, especially in our PCOS patients. It may provide objective decision-making for labs and clinicians as well as patients by providing potentially identifying information about the root cause of failed cycles. It may help us optimize the number of oocytes for cryopreservation with greater individual insights over the statistics and online calculators that are available today. And it may also optimize donor egg cycles by providing more even distribution of quality oocytes to the recipients and better batch size planning, leading to a more efficient use of a valuable resource. And finally, aiding the lab with oocyte batching when there's decisions to be made regarding ixying large groups of oocytes or whether some of those oocytes should be frozen, as well as it has potential benefits to group culture at an early stage of development. So in conclusion, the study demonstrated that a deep learning algorithm can successfully differentiate between the M2 oocytes that will give rise to a blastocyst and those that will not. It directs additional investigation into the applicability of this assessment for other applications within the IVF field. And the findings represent an initial first step to establish standardization of oocyte assessment, a current gap that is crucial for us to advance the efficiency and effectiveness of ART. I would like to know, as this research was challenging for us to gain publication when there's no standard of care for us to use as a comparator, we've simultaneously worked to expand the size of our data set and the data that our model is trained on. We've been increasing the data diversity to a more global scale to ensure generalizability in labs around the world, while aiming to improve the AUC. Currently, our model consists of more than 120,000 oocyte images and outcomes, so it's greatly expanded, with an AUC of 0.69. We're working to deploy a model incorporating hopefully over 175,000 oocyte images and outcomes by the end of this year. So we have big goals. Our research also focuses on creating masks to help segment key regions of the oocyte to facilitate better explainability. And this will be to gain greater understanding of the potential features of the oocyte that are responsible for its quality. Finally, our next steps are to enhance the clinical value of the oocyte assessment scores, which we call magenta. Not only do we want to improve the accuracy, generalizability, and robustness of our model and dataset size, we're striving to push the bar on the clinical outcomes we reach for. We're looking at PGTA employee status of the resulting blastocysts, embryo implantation as indicated by a positive pregnancy test, clinical pregnancy as confirmed on ultrasound, and seeing how much of a stretch it is for us to go to live birth. Although, of course, there's numerous factors that ultimately influence this final goal. That is it. I would like to thank the clinics and labs for their support and collaborations and data sharing efforts to do this research. A huge thank you to my team at Future Fertility for all the hard work to develop this model and our current advances, as well as all the research and analysis, plus persevering to get this manuscript into the literature, and especially to I3 for allowing me to present our research with you today.
Thank you, Jillian, for an exciting presentation. Very, very interesting. Many, many questions from the participants, several asking, can this technology be used on frozen thawed oocytes?
It's not developed on frozen thawed oocytes specifically, so that is something that we're working to study more thoroughly. There are some clinics that have looked at frozen thawed oocytes and see how well we're able to predict on those. And there may be some interesting news out of ASRM regarding that, but our hunch is that we can do that, but we need to continue to validate that.
There are several questions also about the diversity of the data set. Can you talk a little bit more about that?
Data diversity is really important. I tried to touch on that, indicating that we did utilize data from numerous clinics around the globe. So this did come from 6 different countries, 8 fertility clinics. And the reason for that, of course, is to ensure that we are capturing different lab processes, different clinic protocols, different patient demographics within the data. And now that we're at a much larger data set that includes more countries and more clinics in there. And we tested for that generalizability and diversity as well by utilizing the system on the external data set from 2 different independent clinics. So we can see that it was still applicable there and we were still able to validate and get similar results. I hope that answers that question.
Thank you. Sergio, can you speak to how you're using this technology in your clinic?
Hello, everybody. Are you hearing me?
Yes.
Okay. Yes. Nice. Thank you very much for the invitation. So we use since 4 months. It's a beginning. And okay. Hello. For me, it's very useful to evaluate the competence of the cohort, the oocyte cohort. It's very important, each oocyte, but it's most important when you see the patient to analyze with the patient all the cohort of the oocytes, because we saw in the past the results when we have a very poor cohort of oocytes, with lack of fertilization, blastocyst development, and also the eukaryote. So it's very useful to assess the patient with a violet when we freeze the eggs, but with magenta when we use and we talk with the patient the result. Also, we use a lot, and we will present a paper in SRM, the useful in the oocyte program, the donor oocyte program, to share the oocyte between recipients, that the correlation was very good to see which oocyte shared in each recipient. And finally, I want to point out some words of Rita's talk about the need to funding for precision reproductive medicine, and to integrate all these AI platforms because now this is the near future. Thank you.
Thank you, Sergio. So I would like to introduce our next speaker, who joins us from Australia, a way different time zone. So thank you. Dr. Molly Johnson is an early career research fellow at the Monash Bioethics Center at Monash University in Australia. Molly also has a background in reproductive science, but her current research falls within the intersection between social sciences, bioethics, and regulation. Molly is currently working on projects that address the ethical, social, and regulatory aspects of technology, innovation, and human reproduction, including non-invasive prenatal testing, egg freezing, disposition, and donation, the use of machine learning for embryo assessments and assisted reproduction, and MitoHope, the clinical trial for mitochondrial donation in Australia. I'm sorry. So with that, Dr. Johnson, you can present.
Great. Thank you so much for the introduction, Kathy, as well as for the invitation to present today. I'm super excited to be contributing to today's session. And I'm going to be presenting a paper that we published in RBMO late last year. And this paper really was looking at outcomes following egg freezing, with a particular focus on looking at what happens to frozen eggs that are not needed by the person who froze them. So to begin, I just wanted to briefly acknowledge the traditional owners of the land on which I'm zooming in from today, as well as where this work was completed, the Bunurong people of the Kulin Nations, and I pay my respects to their elders past and present, and acknowledge that sovereignty was never ceded. I'd also acknowledge Monash IVF Group for the financial support they've provided for this study, as well as my colleague Amy Webb for administrative support to this project, as well as to this presentation. And my disclosures are listed there. So I know that this is a learned audience, so I'm not going to spend a whole heap of time on background here. But really kind of just to set the scene, I wanted to, say that egg freezing has been around for a really long time. The first live birth from a frozen egg was recorded in 1986, and egg freezing was introduced around the world into clinical practice in the early to mid 2000s. We know that there has been a dramatic increase in the number of people freezing their eggs. This is happening in Australia as well as around the world. And there are a number of reasons why someone may want to freeze their eggs. And broadly speaking, I think these can fall into one of three categories. The first category is what I'm referring to as treatment-related egg freezing, and this is where eggs are frozen in the course of treatment to procure a pregnancy. So the intention here isn't to store these eggs for later, it's just that they are frozen because something has happened. So, for example, it might be on the day of pickup, no sperm sample is available, so eggs are frozen. The other two categories are when eggs are frozen for fertility preservation. So the eggs are not needed right now, but they may be needed in the future. So the first category is when there is a medical reason for this. So this could be an illness or a treatment for an illness threatens fertility. And then the second category of this is, non-medical egg freezing, or otherwise referred to as social egg freezing or elective egg freezing. And while there are a number of motivations as to why someone might want to seek non-medical egg freezing, the reason that they need it is because of the impact of age-related fertility decline. Now, for eggs and gametes that are placed in storage, in many nations, legislation and guidelines determine how long gametes can be stored for. And in Australia, these limits do vary between the different states and territories. And in the state of Victoria, so where I'm from and where this study was conducted, legislation permits that gametes can be kept in storage up to 10 years unless an extension is approved by the statutory authorities. So despite this dramatic uptake that we have seen in people freezing their eggs, so far the data suggests that very few are returning to use them. And this seems to be the case for both people who froze eggs for medical and non-medical reasons. As to why people don't return, the available evidence suggests that there is a variety of reasons for this. So some of the reasons that are commonly reported is that the people conceive without assistance, or they go through IVF and use fresh eggs. Others report that they are single and they don't want to pursue solo parenthood. Others perceive themselves as being too old for childbearing and rearing. And for others, their eggs are still in storage as they're not sure if they'll need them yet in the future. But what I think is fair to say here is that if current trends continue, it's likely that many eggs are going to become surplus to need, regardless of the reason of why they were frozen in the first place. So this leads us to the question of what happens to these surplus or unused frozen eggs. So for patients who are approaching storage limits or who no longer require their eggs themselves, they must decide among three options as to what happens to their unused frozen eggs. So they can decide to discard these, they can donate them to research, or they can donate them to someone else, either through a known donor arrangement, so potentially a family member or a friend that they know who needs donor eggs, or they can donate them to the clinic to contribute to a clinic recruited donor program. Where no decision is made or contact is lost from the person who has eggs in storage, once that storage limit has been reached, the eggs must be removed from storage and discarded as required by Australian regulation. Now, some commentators have predicted that egg freezing is going to result in a large buildup of unused eggs that are ultimately going to be discarded. Conversely, others have hypothesized that potentially these surplus frozen eggs could be a solution to donor shortages, both for reproduction and for research. And a recent meta-analysis reported that among people who have eggs in storage, they report a preference for donating their eggs if they no longer need them. And in fact, discarding eggs was reported as being the least preferred option for surplus frozen eggs. However, this data really only tells us about decision-making intentions. It doesn't tell us anything about what actually happens to these surplus frozen eggs. And this is what we were really interested in. We wanted to know what happens to frozen eggs no longer needed by the person who froze them. Because I think a lot of focus has kind of gone into, well, do people actually return to use their frozen eggs? But there's been very little attention on what happens when eggs are not needed. And, as the trend suggests, this is going to be the case for most people with frozen eggs. It's not known whether that these eggs are left in storage, if they are discarded, or if they are in fact donated on. So to contribute to examining outcomes following egg freezing, we wanted to investigate what happened to unused or surplus frozen eggs. So we designed an exploratory descriptive study to investigate utilization and disposition outcomes for frozen eggs over a 10-year period. We obtained de-identified data from 7 ART clinics from one fertility group based in Victoria, Australia. And this data included the number of cycles that resulted in frozen eggs. So this is any cycle that resulted in frozen eggs, so fertility preservation and treatment-related egg freezing. We also obtained data on storage duration, the outcome of any thaw cycles, and the outcome of egg disposition. Now, a couple of caveats before I jump into the results here. Whilst in the paper and in this presentation, we do present some data on uptake of egg freezing and return and thaw outcomes, I just wanted to say that this is not the focus of this paper. We provide this data just to kind of contextualize our sample. Really, our focus here is on what happens to unused or surplus eggs. And the second caveat is that our intention with this study was not to provide a assessment of the clinical efficacy, but rather to generate data to inform a psychosocial analysis of the outcomes following egg freezing. Because understanding what happens to frozen eggs is important, not just for people considering freezing their eggs and what they might expect following this, but these data are also really important for the fertility industry and policymakers regarding the future provision of this procedure, including the management and use of surplus eggs. So aligning with other studies, we found a consistent increase in the number of patients freezing eggs over the 10 years analyzed, which is illustrated by the line in red. We found the number of eggs in storage greatly increased. So this was an increase of over 1,200%. So from around 1,500 eggs in storage in 2012 to close to 22,000 eggs in 2022. And we found that, as illustrated in the pie chart here, the majority of cycles that resulted in frozen eggs were eggs that were frozen for medical fertility preservation. But over time, as shown in the bar chart there was a slight increase in the number of people freezing eggs for non-medical reasons, as illustrated in orange. So what did it look like for people returning? So we found that 571 patients returned and completed 645 thaw cycles. As in the pie chart below, most of these thaw cycles involved eggs that were frozen for treatment-related reasons or medical reasons. The majority, so over 90% of thaw cycles involved eggs that had been frozen for less than 5 years, of which 47% had been frozen for less than 6 months, suggesting that people are coming back after freezing their eggs for a short period of time. And the outcomes of these thaw cycles was 377 embryo transfers that resulted in 102 clinical pregnancies and 76 live-born babies, which yielded a 12% live birth rate per thaw cycle or a 20% live birth rate per embryo transfer. Moving on to egg disposition, when we looked at this, we found that in comparison to the number of people freezing eggs and putting eggs in storage, the number of people who were relinquishing them was very, very low. And for those who did, the majority discarded their eggs, and this is illustrated in both of the blue bars. Very few patients, in fact, only 23 patients elected to donate their eggs for reproduction, which is seen in green in the bar chart. And of those patients who did decide to donate them, all but 4 did so after having their eggs in storage for less than 5 years. Notably, no one donated to research over the time that we looked at. So what does this data tell us? It shows us that the number of people freezing their eggs continues to outpace those relinquishing their eggs from storage. So this is people who are returning to use their eggs, but also people who are relinquishing them, so discarding them or donating them. The majority of people who did return for their eggs had those eggs in storage for a very short time. This is mostly people returning to use them after freezing for treatment-related reasons, which makes a lot of sense because these are people freezing eggs that are currently in the process of procuring a pregnancy. And people who froze for fertility preservation were less likely to return. Consequently, this means that the number of eggs in storage is rapidly accumulating. It's not being balanced out by people relinquishing from storage. And this kind of prolonged storage of eggs may have serious implications for infrastructure in the future, given that there are physical limitations on cryo storage facilities. So looking a bit closer at these disposition outcomes, we found that most surplus eggs were discarded. And when we looked at the duration of storage at the time that these eggs were discarded, we found that equal proportions were discarded at less than 5 years of storage, 5 to 10 years of storage, and over 10 years of storage. And I think that there are a couple of interesting things we can pick up on this. The first is that there doesn't seem to be a clear pattern on when patients decide that they no longer require their frozen eggs. Some people make that decision after storing their eggs for a short time, others hold on to them for a bit longer. So I think one takeaway we can take from this is that if patients do need support in determining what they do with any eggs they no longer need, this support should be made available to patients across the storage period, because this data suggests that it's not just people kind of waiting to the end of their storage and when they need to make these decisions. The second thing that I think is interesting here and for us is looking at those eggs that were discarded at 10 years or more. And it is not clear from the data that we obtained whether these eggs were abandoned, which means that patients cease paying their storage fees and do not respond to contact attempts, or if the patient simply deferred making a decision about what should happen to their eggs until they reach these statutory storage limits and essentially the law decided for them and made them to be discarded. And we know that looking at the research on people who have surplus embryos, they say that embryo disposition is very challenging, and often they defer this decision until they reach statutory limits, so the embryos are discarded for them. And indeed, some of the work that we've been doing with patients with frozen eggs, these patients have described to us that they find this decision very challenging and often do defer the decision until later in their storage period. And this has implications for support needs. Very few people donated for reproduction, which I'll talk about a little bit more shortly. And quite notably to us, at least, was that no one donated to research over the 10 years that we looked at. And the reason was that for this is that the clinics that were included in our study were not affiliated with a research project requiring eggs, donor eggs over the study period. Clinics in Australia also do not store eggs prospectively for future research. Rather, they require patients to give specific consent to an active research project. So in practice, what this means is that if someone wants to donate their eggs to research, if there is no research study that is currently recruiting at the time that the patient wants to or is required to relinquish their eggs from storage, then the option to donate to research is not available to them, and they may have to discard their eggs instead. And indeed, in our work with patients, several of them have told us that this is exactly the case, that they really wanted to donate to research, but were told they were not able to, and they reluctantly discarded their eggs. So I think that this raises some really interesting questions around models of consent, what is needed to respect or even enable patient autonomy, and how we can best capture eggs as valuable resources needed for research. One really interesting finding from our study was that the outcomes of egg disposition that we reported conflict with all of the kind of research on people's intentions if their eggs become surplus to need. So as I mentioned earlier, people report a preference for donating their eggs if they don't need them. And in fact, discarding eggs was the least preferred option. However, in our study, we found that the majority of eggs were actually discarded and very few people decided to donate their eggs. And while I acknowledge that intentions do not necessarily predict actual decisions, it is striking that so few patients decided to donate their eggs. Now, it could be that preferences change over time, and indeed a recent study led by Lucy Cawley from the University of Melbourne has in fact reported this, that patients over the storage period, their intentions for what they want happen to their eggs does change. And this is influenced by a variety of factors, including whether that they have achieved their family aspirations or not. But I also think that there could be certain barriers that are preventing people from donating their eggs. And I just wanted to kind of spend a few moments talking about that. So I think that, there are an array of kind of potential barriers that could be preventing people from donating. And I wanted to talk about kind of 3 broad categories of this. So the first is around need. So I've already spoken about the requirement for an active research project, and this is clearly limiting people's ability to donate their eggs to research. But I also think that there could be a lack of awareness of the need for donor eggs for reproduction. So our research with people and our forthcoming papers on this report that people with frozen eggs have a lack of awareness of the option of donating, that some people were just told us that they didn't know they could donate their eggs to other people. And others reported that they didn't know that there was actually a need for donor eggs. So there is clearly a lack of awareness here around that eggs are needed. I also think eligibility criteria could be disqualifying some people from donating. And although I'm sure that this eligibility criteria does vary between clinics and jurisdictions, this criteria does apply to be a donor for the purpose of reproduction. And I just wanted to give one example of this. So for the clinics that were included in our study, donors must be under the age of 36 years. And when we applied this criteria to our sample, so anyone who froze their eggs over those 10-year period, we found that 55% of our sample would be disqualified on the basis of age alone. So clearly these criteria are limiting the amount of people that can qualify as a donor. I also think that there might be moral concerns associated with donating surplus eggs, particularly donating to other people for reproduction. So issues around donor anonymity, which is prohibited in Australia, the various meanings attached to genetic relationships and parental responsibilities have been cited as weighty barriers to egg donation and are likely preventing people from donating their eggs on. So these are just some. I'm sure there are others, potential barriers to donation. But I do think that further research is really needed on understanding what these barriers are, and more importantly, what can be done to mitigate or eliminate any barriers. And this is needed not just to address donor shortages, which we know is a global phenomenon, but also to better support patients with frozen eggs. So a lot of the patients that we've spoken to in our research told us that they felt very invested around what happens to their surplus eggs. They spoke a lot about not wanting these eggs to go to waste, that they should go to something. So I think that we really do have a duty to ensure that patients are supported to determine the fate of their surplus eggs, and that their preferences for what happens to these eggs should be respected where possible. So just in summary, with this paper, our kind of key take-homes from this was that we found that the number of people freezing eggs and putting eggs in storage significantly outpaces those returning to use or to relinquish their eggs from storage. And contrary to early hypotheses, our data suggests that so far very few eggs are donated on. And we think that the implications of this is that new strategies may be needed to avoid an unsustainable buildup of frozen eggs, but also to ensure that patients are supported to make decisions about their surplus eggs that align with their preferences and their values. So I'm going to leave it there. Thank you very much.
Oh, thank you very much for this very interesting talk. Molly, I would like to start our Q&A by asking you a question. Do you know, I realize that this might be a little bit country specific or region specific, but do you know if these trends that you have observed in decisions or opinion or wishes of patients are generalized? Are there any global trends that can be recognized, or it is very specific of Australia?
Yeah, so there is really little data on what happens to eggs that are no longer needed by the person who froze them. I only know of kind of 2 Australian studies, so my own and another group in Melbourne, and our results are aligning quite closely. So we find that people, report that this decision is really difficult, and that they, really kind of struggle with the options that are available to them. But what has been really striking in our research is that a lot of people tell us at the time of freezing, they never even consider that this is a decision that they have to make in the future. So I think that that finding alone kind of makes a duty for fertility treatment providers, that this is something that we should be raising with people before they freeze their eggs, given that we're hearing that this can be a really hard decision in the future. In terms of outcomes, there is really little data. So this is, I haven't seen a lot beyond Australia around what happens to these surplus eggs. But anecdotally, I am hearing that a lot of eggs are just left in storage.
Yeah, if I can say, at least for Spain, some of the barriers to donate to others that you mentioned, namely being like qualifying as donors in a sense, are exactly the same. So I think there might be some common ground in several countries there. So now we can start. Thank you very much. The Q&A, the general Q&A session, and I would like to start myself before giving space to my other co-hosts, and with a question for sorry, Julien, and at the same time for Sergio. One of our listeners in the audience asked something that I often asked myself. I know, to Julien, to you. So it is really, let's say, quote unquote, useful to grade eggs, considering that in many cases, especially for patients, there are so few that at the end they will all be used, and we will not discard eggs. And so this is a question for you, but also for Sergio, which has a more practical in the clinic use case of this technology. So how do you manage this?
Oh, Dr. Sergio, we can't hear you. Oh, you're on.
We cannot hear you, Sergio. You're on mute.
Excuse me. Thank you, Rita. Excuse me. We decide to use in all the cases. So we are learn about this first stage, but it's very useful. For example, as I said, it's very useful to assess the cytoplasmic immaturity that we can change with a personalized ovarian stimulation. So it's a very useful information to decide different ovarian stimulation protocol, for instance. And again, it's in this first step, very useful in our egg donor program, where we share oocyte between 2 or 2 recipients. So it's make more efficient the program.
Perfect. And Julien, you wanted to give your input.
I'll comment as well. I know it's a big question, is why would we assess the oocyte? They're all going to be utilized. Usually this is the case. I think there are some more places around the world where that isn't the case. Maybe you cannot fertilize every egg because you do not want an abundance or surplus of embryos frozen, because then sometimes legally you're not allowed to destroy embryos. So I think that is actually sort of one big thing that might come of this and the importance of it. Additionally, maybe you're performing ICSI with, a really severe male factor case and you have a large number of oocytes. Do you want to ICSI, your top eggs first with the best sperm you can find? Potentially you want to split that cohort and maybe freeze the other ones. There's a lot of reasons for it. And I think as well, what we've done up until now as embryologists is we've only inferred egg quality. So in the lab, if sperm is poor and embryo development is poor, we assume it's a sperm issue. But how do we know there's an actual egg issue without assessing the egg? So it may take many rounds of IVF to realize that you actually have an egg and a sperm problem. So, that is another reason for utilizing, our oocyte assessments in your IVF ICSI cycles. One quick comment as well, we're talking about ICSI because they do need to be denuded oocytes.
that there was in fact one of the questions. What happens if you're doing classic IVF, and how do you assess that? The answer is you don't, basically.
Exactly. Unfortunately.
Yeah.
Would the technology work if you did the short insemination on a conventional?
I've been wondering that. It's something I would like to study and understand more. You know, obviously some changes are going to occur, you know, if fertilization has initiated, but we have looked at eggs, you know, pre-ICSI and immediately post-ICSI, and we're not seeing much difference in our accuracies and our AUCs on those. So it'd be interesting to also look at that group of oocytes. So if anyone wants to do that study, get in touch. It would be wonderful to find out.
I would like to ask a question to Danilo. In your talk, when you discussed mosaicism and how to report it or not report it, and the clinical meaning of it, at one point you said that you know, up to 70% of clinicians would not transfer an embryo that is with the, you know, the tag of being mosaic, and you somehow link this to, you know, confusion in nomenclature and confusion in how we call things. Would you also consider that there might be some sort of defensive attitude? You know, once you know something that, well, is kind of a diagnosis, even though it is not, then why should you transfer?
Yeah, I mean, that's the whole misconception, I think, because the idea of reporting mosaicism in the first place was that these embryos should have been deprioritized for transfer, but not transfer at all. That's pretty much the idea. But at the end, it turned out as a no-go, right? And then many clinicians did not transfer them, or the patients felt as if they were transferring abnormal embryos that they are not. So the point here is that the call of mosaic in the first place based on intermediate chromosome copy number might not be reliable, at least not always. And at the end, you might be transferring like fully aneuploid embryos without knowing, or the other way around, not transferring fully euploid embryos. So as soon as mosaic embryos are transferred at the end, I think that is not bad to report them. But if the risk is that these embryos are not transferred, it's better not reporting them as mosaic. And this is what we have always done. So in our clinic here in Rome, we have never reported mosaicism from day one. So we've always stuck to a euploid, aneuploid call, and that's it. So we never faced the problem because we felt we didn't have enough information to counsel patients on what to do. And we as clinicians and embryologists, we didn't have a clue of what to do as well. So that was pretty much the idea.
This is for Sergio and Jolene. Do you ever think the egg AI technology will be used to increase efficiencies in the laboratory? I know at least in the United States and probably all around the world, there's a massive shortage of embryologists, and the new buzzword is access to care, getting care for everybody, increasing patient volumes. But you know, sitting there all day, seeing so many oocytes. And as Danilo said, there's an effect of the biopsy technician on biopsy results. I'm sure there is a technical impact on ICSI performance and embryo quality or competency. Would you ever exclude the lower grade oocytes and not even utilize them for the patient and just concentrate on using the oocytes with the highest potential?
I think it's definitely a question we have, and I think it's, you know, a little bit related to what I was talking about just previous to this question. I don't know that we would get to the point, or at least not yet, where we're saying discard those oocytes. Maybe we're going to end up with more in storage that then we have to make decisions about later, you know, just like Molly's conversation. But I think, you know, at least for efficiencies and not freezing or not creating as many embryos and spending our time on the top quality eggs, you know, maybe a more efficient way to utilize our time. And and our resources within the lab. And I agree, sitting there for hours trying to inject many eggs, you know, as much as we try to give 110%, our quality is definitely decreasing by the end of the day. You know, it's hard, we're only human. So I think there's going to be, you know, efficiencies like that we'll want to understand better by utilizing this sort of technology and what the power of it and the insights can do for us.
In the medical point of view, efficiency also is to make good decisions. So information always make better decisions for doctors, for embryologists, and finally for the patient. And also, this is also the efficiency in an holistic point of view.
So I would like to have a question. I don't know if Molly, you went into this level of granularity, but someone is wondering whether there is an effect of the type of research that patient might imagine will go on with their oocyte, or the type of a procedure that the oocyte will undergo that would perhaps influence the decision to not donate to research. Have you encountered that?
Not in the research that we've been doing at the moment. So for this paper in particular, you know, there was no research, so we couldn't really kind of get into looking at the, I guess, trends of what research was donated to more readily over others. However, this is something that we are working on at the moment. I have a really brilliant student who's doing a research project looking at these exact questions in terms of, you know, how much information does a person want to know about a potential research project in order for them to feel satisfied that they can make an autonomous decision to donate their eggs forward. So I don't have an answer for you now, but I'd like to say watch this space, because this is something that we are actively working on.
If I can make a personal contribution, I used to do lots of research with the oocyte that are donated by patient and by oocyte donor, and at one point we had to make sure that in every consent form we would specify very clearly, even though the project was obvious already that it was not about that, but we would make very clear that the oocyte would not be fertilized, even though there was no indication, of course, in the protocol that it would happen. We found to be sort of a worry or a fear that was a stop for many women to donate.
Yeah, and I absolutely understand that. In some of the research that we have done with patients, you know, they do talk about that, saying that that is a concern for them and one of the reasons they don't want it to donate to someone else. But, you know, under kind of the regulation that governs research in Australia, we operate under a specific consent model, which means that we would be required to give all of the information regarding the research project to a prospective donor so that they can make a decision. So they should be aware of how their eggs are going to be used, how many eggs will be used, and what will be the outcomes following that.
Yeah.
Molly, do you have any thoughts on what's happening in the United States with employers actually promoting egg freezing as one of their benefits? And I think the definition social is actually going to go away, because it's almost an employer driven decision now, you know, to attract more females to the company, to keep their female employees engaged in the company. But then it's also really not conducive to the female, because they are sort of, they're having a work-life balance in a sense, because they're freezing their eggs, but they're also delaying their family building years. And that it's you know, it was person driven, now it's employer driven.
Yeah, I actually wrote a paper on this a few years ago, and we did actually do some work on public attitudes in Australia to, you know, what do they think about employer-sponsored egg freezing? And our data suggested that, you know, some people actually really welcomed it. They thought it would be, you know, a really great thing. And a lot of those reasons kind of came down to, well, this is a really expensive procedure and a procedure that not everyone can afford. So if this is going to be available and subsidized through an employer, that could help democratize access for people and give them access to a procedure or a technology that they wouldn't otherwise have had access to. Conversely, though, people do comment on, you know, what is the context in which this is happening? So are these companies putting forward this as an option, as the only kind of thing that they're giving and saying that this is how we support people to have children, when in reality, that's not actually supporting people to have children. That's just kind of deferring this childbearing to some point in the future. And if these companies don't have, you know, family-friendly policies that also support people to take time to have leave, to have flexible work arrangements, it's hard to say that this is a family-friendly policy. There has been some data and some research with people who do work at companies that offer this. And what that data suggests is that these people don't feel pressured to freeze their eggs. So the kind of having this as an option is not coercing them into freezing their eggs themselves, but they really do kind of come back to this, you know, it doesn't solve the problem being that it's very difficult to combine family building as well as career building, particularly for women, given the limitations on our reproductive lifespan.
So I would like to perhaps finish with a couple of questions to Danilo. Even though these topics were not strictly in your review, there are some questions about, you know, should we biopsy day 7 embryos? Does it have an effect on reproductive outcomes? Is it, you know, should we use these embryos? And so what's your thought about it?
Well, that will require a full presentation maybe to go with. But you know, our experience in Italy is that we have this law 40 from 2004 that basically prevents us from discarding embryos, at least viable embryos, whatever you call it, viability. Okay. So basically day 7 in Italy are pretty common. So we have to keep them up to day 7 unless they degenerate. So I would say that about 15% of embryos that we biopsy every day are day 7 blastocysts. Okay, so we have a large experience with them. And these embryos are more often of a lower quality, and that perhaps might be connected to the fact that they are slower in their development and therefore are even less euploid. But perhaps the lower euploidy is due to the fact that they are of a lower morphology rather than the pace of development. So if you have an embryo excellent quality in day 5 or day 7, they might be they might have the same chance of being euploid. This being said, when you transfer euploid day 7 embryos, they implant less with respect to day 5 or day 6, but they're not incompetent. Okay, so there might be patients that might really benefit from these embryos because maybe it's the only embryo they produce or the last embryo they produce, or even in a family planning view, they might be second children from the same cohort. Okay, so that's pretty much the idea that we develop, and there is a paper in Human Reproduction we published specifically on this topic. So I don't see any problem with that. Obviously, cost-wise, you need to put them on a balance. So whether the patient already has many day 5 or day 6, maybe it's not needed. But in a patient population like ours, that is like 38, 39 years, poor ovarian reserve, they make the difference. So we estimated like 5% relative increase in the chance of live birth if you include them. So that's pretty much my experience. So although you have a lower reproductive competence, something you need to acknowledge to your patients, they are not incompetent. So that's pretty much the point.
And for me to just clarify, when these day 7 are transferred, are they transfer in a synchronized?
Yes, sure. Yes, sure.
On day 7.
That's the other thing. We, if you're not biopsying them, so you know, freeze-all it's obvious when you do PGTA. If you're not biopsying them, I would rather suggest to still vitrify them and transfer them on a day 5, day 6 progesterone.
Okay, perfect. Perfect. So I think we are getting pretty close to the end of our seminars, and so I would like to thank, of course, everyone that took part in this seminar. My co-host, Dr. Kathy Miller, Molly Johnson, Danilo, Judith, and of course Sergio. And of course, every one of you that have been listening and contributing and asking questions and present. There are hundreds of people connected, and it's really a pleasure. It's been a pleasure to be here with you.
And I'd also like to thank Rita for co-hosting the webinar with me, and Future Fertility for sponsoring the webinar. And we cannot forget our great I3 team who has produced the webinar for us. I'd like to thank the organizing committee of I3, Jacques Cohen, Peter Nagy, Marianne Savetes, Thomas Elliott, Fran Farley, Giles Palmer, and Violetta Suara. And please join us for the next I3 session called the Night Watch. So for all, thank you.
Thank you. Bye-bye.
Thank you, everyone.
Bye, everyone.